So let's talk about epidemiology and public health. All right. So again, this was chapter 19 in your old textbook, no longer the case, right? As far as the session goes, and even if we're in a regular semester, right, this is the light at the end of the tunnel. But be sure not to fall on your face here right at the end, right? So focus and finish strong. Just because you can see the finish line doesn't mean that you don't need to keep on putting effort in. Or like this video, power walking, right? Olympic sport. Oh, so close to the finish. Okay. He looks very tired. All right. I know you're very tired, but please hold on. Right. So we're going to talk about some basic terminology involved in epidemiology, learn some of the general principles, kind of talk about a little bit. Um, I mean, epidemiology definitely, but maybe more even public health as a field. Um, what they're doing, right? And because of the work that epidemiologists and public health officials do, right, this is where we get health policy. This is where we figure out how to treat diseases. So folks in the public health field have been very active during this COVID pandemic, trying to figure out the best ways to prevent the spread of the virus, right? And often, the thing that I love about public health is that the solutions are, I would say, relatively simple, but have a major impact. And sometimes it's just reminding us of the small things, all right? So, washing your hands, right? Keeping your social distance, right, of 6 feet or more, right? And I realize that there's some data that says that might not be enough, but that's fine. Right? We'll put that aside. And so, really, kind of simple solutions that can have major effects. This is an old slide. I use this on your um, very first presentation, and maybe someday I'll update it, but it still holds relatively true. All right, and here you can see this is in the United States, and starting around 1900, right, going down to about 2000, you see that we have a very kind of steep decline, right, in the death rate associated with infectious disease. You see a spike here for the influenza pandemic, all right? But other than that, it's been a pretty steady decrease. Remember, we pointed some of these out here, right? You have the development of state health departments. You have chlorinated water, right? So safer drinking water. You have the introduction of antibiotics. You have kind of more common vast vaccinations. And so you see a pretty steady decline, right? You see it start to go up here a little bit, right? Kind of rises up. Again, some of this is going to be caused by the HIV uh, uh, pandemic worldwide, but epidemic specifically in the United States. And what we also see with HIV, slight increases in tuberculosis. So sometimes those things play on each other. I'll have to see if I can find an updated one of these, because I'm sure there will be a small spike, not a huge one, but a small spike um, for COVID-19. Okay. Um, one of the things, and I'll talk about this more, these are a couple slides on, I've designated it biblical epidemiology. Um, and we'll talk about this more in leprosy, but it is really interesting that if you look through chapters 13 through 15 in Leviticus, you will find some basic um, public health, we'll say, principles, right? Laws on sanitation, right? So how do you treat clothing? How do you treat housing? How do you, even this idea of hand washing, we kind of see that mentioned in these chapters in Leviticus. And, at this time, uh, the writers of these books, and I don't know, is Leviticus, did Moses write that one? Does anyone remember? No, I can't remember exactly either. I'll have to double check that to see if the authors know. But anyway, right? It's really interesting, that there's these laws in Leviticus, and it's not around. It's not until around the 13th century that a lot of folks actually start to uh, do the things that are mentioned in Leviticus, and we, actually see leprosy kind of. Um, Rain down or pull down a little bit, right, in a good way. Less infections, not as common. All right. But clearly, right, the people that wrote this book did not have an understanding of mycobacteria and of antibiotics and all this stuff. But right, we still find these important laws. Okay? Leviticus 15, right, specifically talks about hands being rinsed, clothes being rinsed after contact with infectious discharge, right? Stuff that we really take for granted. And you're like, well, why is this such a big deal if this was part of the Old Testament? And we'll see, we'll mention it. A couple of folks, hand washing and sanitation in medical facilities and practices did not start to become common until later into the 19th century, right? So we're starting to see late 1800s, even into the early 1900s. And it was actually met with a lot of opposition, right? So this is my boy, Ignaz Semmelweis. And so Perpella fever, which was causing a lot of mortalities on the floor of the hospital he was working at, he decided to try washing his hands in between seeing patients, and noticed a significant decrease in the mortality of his patients, right? So he immediately started to see a decline, right, in the number of his patients that were dying just by simply washing his hands. And I believe this was 1830s. And when he started to try to implement this or talk about this, he was met with a lot of opposition. We don't really talk about Joseph Lister, but if you heard of Listerine, right, that's who it's named after. But Joseph Lister decided it would be a great idea to try disinfecting instruments between surgeries. And he was met with a lot of opposition also. And so these are common things that we take for granted that have drastically changed the medical field. And although they seem obvious to us, they were not obvious to people at the time. And it took a lot of hard work by these people that believed in them to have these become common practice, right? So we already mentioned him. Yes, pay attention. He's a good guy. So John Snow is considered one of the fathers of epidemiology. And so in 1854, London had a really bad cholera outbreak. And what John Snow did is he geographically mapped the cases of diarrhea, right? So he basically got a big map of London and figured out where these cases were coming from. And then he was actually able to trace it back to a single water pump in London that had become contaminated with fecal waste. And even after he identified this pump, the city board or city council, however London works, was reluctant to admit that there was fecal contamination of their water supply. And it was not, I guess, as well received as he thought it might be, right, when he presented a solution. But what does happen is, right, they cut off this water source and they see a decrease in the cases of cholera. All right. One of the things that makes this time challenging is that, again, you do start to have individuals like Pasteur, Robert Koch, really kind of promoting this idea of, germs cause disease and they spread in interesting ways. But cholera, right, was one where people thought it was contagious, right? And that it was spread person to person. And that's not entirely true, right? It's typically spread by contaminated water. Now, if you're living in tight quarters with someone that has cholera, right, you could possibly get it, again, from a contaminated water source or fecal contamination. But you can't get cholera from breathing on somebody, type of thing. And so this was a hard kind of thing to overcome. So just some basic kind of terminology, right? So epidemic, right? You can see here epi above people, right? Is one location in population, right? So the example I typically use is HIV, but we can even use COVID-19, right? The United States has a COVID-19 epidemic, but it is part of, right, also a COVID-19 pandemic, right, which is going to include multiple continents and populations, all right? And so you can use that terminology in different ways. It just kind of depends on what population or how many other countries you're trying to bring in, right? Endemic, right? So a baseline rate of disease, and typically we're looking at a specific location, all right? And so, certain diseases are endemic to specific areas, right? And again, that baseline, rate of disease is important to understand and keep track of, because once we go away from that baseline, that endemic level of disease, then we start to get concerned, okay? And so again, like today, like Mercy was mentioning malaria, all right? Malaria is not an issue in the United States. Now, it used to be actually way back when, even into the early 20th century, right? But it's not a problem here anymore, but you still have areas of Central South America and Africa, right, that it's endemic to, right? So we don't have that here in the States, although I'm sure there is a fear that it eventually could come back for a variety of reasons, all right? So when we talk about epidemiology, and we talk about public health, one of the things that we need to understand is, what are the reservoirs for disease, right? So what is carrying, or how are these pathogens being carried, right? And these are just a couple examples, right? And so you guys can be reservoirs for disease. It's kind of funny. This picture is old, but it reminds me of all of the, well, I'll call them fools that were partying down in South Florida when we knew that we should be social distancing, right? So there we are, all right? A lot of our livestock, right, are reservoirs for disease. And this is, right, very relevant. I'll have to see if I can go back and find that video. Maybe I'll show that to you guys tomorrow, or I'll see if I can find it during our break that we'll take here in a little bit, right? But animals are carriers, right, for certain viruses and diseases, right? And in the case of COVID-19, right, or the SARS-CoV-2 virus, one of the sources we think it came from is bats, right? And so it might not necessarily cause a lethal disease in those organisms, but when it does jump from something like a bat to us, right, then we can have a lot of issues. And keeping animals in close proximity and us interacting with animals that are in close proximity can be kind of dangerous, right? Insects, right, are a great reservoir for a lot of different diseases. I think one of you guys, one group is doing Lyme disease, right? So here you can see our friend, the tick, right? Great reservoir for that. And I think I gave someone Chagas disease to do. And so I'll say that this is a kissing bug, right? Oh no, here's a kissing, this is actually a kissing bug that spreads diseases like that. And then one of the ones that kind of gets overlooked, and this is really applicable to bacteria, protozoa, and fungi, right? A lot of them live in soil, and so the soil is a great reservoir for disease. To a certain extent, right, we can control, right, how big our gatherings are, right? Or we can control disease in people. We can even do things for insects, right? So the US has spent a lot of money on trying to kill mosquito populations. And a lot of research is actually focused on how do we kill mosquitoes that are becoming resistant to pesticides and perhaps relieve some of the stress in malaria-torn countries, right? What are best practices? What are things we can do differently for our livestock? But one thing that's really hard to control, right, in a lot of cases is soil, all right? And so that can have to be a challenge for us, right? Another reservoir I just want to throw up there, right? This is a prairie dog, right? And a lot of people think they're fun and harmless, right? But don't be fooled. There's actually been a couple cases of the plague in the United States that happen every once in a while because people decide to try to take in pet prairie dogs, and prairie dogs can carry the plague. So next time you're out, if you see a prairie dog in Cleveland, Tennessee, right, don't pick it up and take it home. All right, so we talk about reservoirs, we become really interested in transmission, right? And again, reservoirs, we just mentioned it on the previous slide, can be anything: people, animal, food, water, air, dirt, right? All sorts of things. Pretty much anything you can think of is capable of transmitting a disease. Excuse me. Now, where you have to kind of start to tease these things out is, some of them are living, some of them aren't. So a vector, right, is any living thing that can transmit a disease, right? So again, the people, animals, right? If you want to divide them into groups, insects, all that fun stuff, right? It has to be a living thing that transmits the disease. But then you also have fomites, right? And so this is any non-living thing that transmits disease, right? And this does not have to be, complicated. One of the things that you've heard about in COVID-19, and I haven't looked too deeply into these studies, but there have been studies where people are basically trying to figure out how long does the virus survive on certain surfaces. All right. And so if, who I'll pick on, I'll pick on Rachel S., right? Let's say she has like the flu, all right? And she comes to class because she doesn't like to miss, class time. And she's coughing all over the table, all over the door handle, right? And the virus can survive. Often they can't survive too long, but they can survive for a small amount of time on those surfaces. And then, Glory comes in. She has the class after Rachel. She sits at that same table, touches that, everything that Rachel touched, uses that same door handle. And then Glory has, influenza. All right. So again, that's what we mean when we say a non-living thing that transmits disease, right? Because if we're talking about a virus or a fungi or a bacteria, right, or a protozoa, right, a non-living object like a table or a piece of clothing, right, does not provide nutrients for a pathogen, but it might provide, some shelter temporarily for that pathogen, and they survive for a while. So you have to be careful, right? And one of the things that we're noticing, with COVID, which is a good thing, is that, exposure, right, to UV radiation outside really seems to limit the time the virus can survive, on a surface, which is good news for us, especially as we're entering, right, the warmer time of the year. I'm not saying that we're lucky at all, but I do, truly believe that if the COVID-19 pandemic was happening, or it started more during the winter, it potentially could have been even worse when you had people more kind of clustered and clumped up there at the beginning. So who knows, right? But a lot of different things to consider and look at into that. So when we talk about, right, transmission and perhaps the start of an epidemic and a pandemic, or how many people are going to be affected, right, we have to consider two things. And I think a lot of this makes sense to you guys. So you have to consider, right, aspects of the host and aspects of the pathogen, all right? And so this is where it gets kind of tricky, right? So here, right? Immunity. Right? Are we relying on herd immunity? Have you been immunized? Is this a virus or disease that people have been naturally infected with in the past, and so they're immune to it? This is one of the reasons that we're having a COVID-19 pandemic right now, is that people don't have immunity, right? This is the first time that we're seeing this virus. And Professor Perry can um, not really correct me, but add knowledge as she knows. What I haven't seen and I haven't searched for, and I don't know why I'm just thinking of this now, is if anyone knows people that were infected with SARS-CoV, the original, the virus that caused the SARS pandemic, if any of those folks have immunity. Professor Perry, have you seen that at all? Have you seen anyone mention that?
I have not.
Okay, I know it was a pandemic, but the number of people that it infected was significantly, less than this. It was more lethal than SARS-CoV-2. It was
Mhm.
not as easily transmitted, and so I don't even know, how big of a study or sample size that would be. And I guess not that that matters that much, because that's still a very limited part of our population that may have some type of immunity to it, right? So we are all very susceptible to this virus, right? Health, again, right? We can kind of go down. COVID-19 is just such a great example of why we're concerned about these, right? So what we know is that over 90% of hospitalizations that are related to COVID-19, all those patients coming in have one or more underlying medical issues that they're dealing with, right? We know that pulmonary disease, cardiovascular disease, make patients much more susceptible to the virus, right? So how healthy are you at the time of infection? Age, all right? We know um, that, once you start to get, especially into that 60 plus, right, the risk uh, um, for a severe COVID-19 infection go up. Now, right, and I'm sure you've heard one of the things that's scary about COVID-19 is that we do see younger folks, even infants and toddlers, although not still in high numbers, but enough to catch our attention, that are dealing with severe symptoms of the virus, right? And again, I feel relatively confident that as time goes on, we'll find out that there's probably some type of underlying issue that we're not aware of, or a link that draws them together. But it is scary, especially when you don't know what that is. Gender, I'll be honest, I have not looked to see, um, although I thought I did remember actually glancing somewhere that there might be a difference in infection rates between men and women. Did someone mention that in one of their articles? I can't remember. I'll have to check that. Um, uh, Culture, right? And so culture is meant to refer to, different cultures have different customs, different practices, different ways that they look at a family unit, right? How many people are you interacting with? What are your living conditions like? What are your burial practices like? I always like to point out here, um, for Ebola, um, at least some of the outbreaks that we've seen, we figured out, that during their burial practices and their ceremonies, right, there's a lot of handling of the body. And so public health folks actually came in and said, hey, if you handle the body differently during the burial practice, you decrease the chance of transmission. And it was a really kind of quick fix to the problem. One of the things that I didn't put in here, but I need to add, is socioeconomic status. And so I'm sure you've seen reports, and there actually are some morbidity, mortality weekly reports, which we'll talk about here in just a second, that I haven't fully read, that talk about um, disparity in infections and COVID-19 infections in even, we we're very sensitive to this right now, but in African American populations in the United States, right? And so there's a lot of things that factor into this. Genetics, and again, certain ethnicities may be more susceptible to certain diseases. Um, you might have, we could even add here, again, if we stay on the COVID-19, people that have autoimmune disorders appear to be maybe more susceptible to severe viral infection when we talk about COVID. So there's a lot of different things, right, that play into the host that we have to kind of account for. And public health officials and epidemiologists, right, kind of study all of these, right? We'll say kind of risk factors for developing the disease. And we'll talk about that more in just a second. You also have to think about the pathogen, right? Virulence, dose, incubation. So basically we're looking at how good is that pathogen at doing its job, right? We know there are some pathogens out there that it takes one individual virus, right? One individual virus is enough to induce disease in somebody. One bacteria, all right? Some pathogens, right? It requires a really big exposure, right? Somebody basically has to sneeze in your face, right? Or you have to consume a large quantity, of a pathogen, right? When we talk about virulence, right? To like how good is it at causing infection? How is it causing infection? What is it doing, to your body? And then, incubation. This is something that gets really tricky from a public health standpoint, especially diseases that have a long incubation time, right? So we'll talk today about the HIV epidemic and pandemic, and what makes HIV difficult is that someone could go, perhaps, right, although not incredibly common without medication, but could live up to 10 years, right, with the virus in their system before they have severe consequences, right, resulting in their death, right? And during that time, right, a lot of people could be exposed to them. And then from an epidemiological standpoint, I don't know about you, but I can't even remember what I had for dinner yesterday, right? And so trying to talk to somebody that comes in and tests positive for something that they may have caught 10 years ago, right, becomes very difficult to kind of trace and track how that disease started. And it also becomes kind of difficult to respond, right? We don't go over it specifically, but with HIV, the early 1980s, it took us by surprise, right? Because things had been normal, and then all of a sudden you had all these people start to come in with these really rare diseases and issues, and we were overwhelmed for a time. All right. And so, one of the things that public health officials are interested in, right, is how do you stop this chain of infection, right? So here you have your reservoir, how it's leaving that reservoir, right? So you have the transmission, right, to the new host, right, or new patient, however you want to look at it. How does it enter that patient, and then is that patient susceptible, right? And so the idea would be, as a public health official, right, how do you interrupt one of these parts, right? If you can perhaps control or eliminate the reservoir, right, that's fine. If you can control it leaving the reservoir, right, prevent it from being transmitted, susceptible host. And so, one of the things we could do is if we have a vaccine, right? Well, if you vaccinate the susceptible host, and even though you get to these points, right, you still stop the infection. And one thing I wanted to point out too, those of you that are interested in being PAs, nurse practitioners, or even MDs, a lot of schools now are we'll say strongly encouraging people in those fields to also get public health degrees, right? And a lot of bigger schools will have kind of joint programs where you'll be working on a public health degree while you're getting your medical degree. So that may be something that you want to consider in the future. And also, shameless pitch, right? For UTC has a new public health program that is doing really well. It could be an option if some of this stuff interests you. All right. So when we talk about epidemiology, all right, there's kind of three kind of purposes, I guess, if you want to divide it into that. So epidemiologists, right, investigate, right? They look for cause and effect of disease, right? And so, this is helping them find or identify new diseases, right? Surveillance, right? Monitoring known diseases. And if you go online and look, the CDC and the World Health Organization have something called a notifiable disease. And so when a doctor sees one of these diseases, right, they basically fill out a case report and send it into the CDC so the CDC can track it, right? And right, part of the surveillance, I would kind of, along with investigation, right, is being on the lookout for new diseases, all right? And then the public health branch, right? And this is maybe where a lot of you have, a lot of interest. So hospital-acquired infections, those of you, regardless of your affinity for public health or not, caring that much for public health, if you are going into any type of medical practice, right, this is becoming a very big issue, right? And I think Professor Perry can agree, especially with her work in a mycology lab. One of the worst places to catch an infection would be at a hospital or in a hospital-related setting, right? Any of you that have spent time in a hospital, or if you're like Professor Perry, in a hospital lab, right? The cleaning solutions and the precautions that they take, I would say, for most good hospitals are very, very high, right? It's something they take seriously. If you are catching something that has survived some of those cleaning procedures, it is probably going to be a pretty hardy pathogen. So, this is something that we're very concerned with, right? And in public health, and this is where some of you may be really interested, right? Best practices and education, right? A lot of the public health field, again, is figuring out solutions that can be easily implemented to stop the spread of certain pathogens, right? And a lot of this requires educating and interacting with doctors and with patients. And I think, unfortunately, this part of public health, I think, is underappreciated in society until we get to something like a pandemic, right? So when you're talking about our 6 feet apart and our social distancing and all that stuff, right? That is public health. Okay. So let's talk a little bit about epidemiology and some different kind of studies that they do and how they kind of ramp up in complexity. So in epidemiology, we have something called a descriptive study. And in a descriptive study, actually here, why don't we take a break? It's 9:05. Let's come back at 9:15 and we'll start here and work our way through. All right. So I'm going to pause this. You guys take a 10-minute break, be back at 9:15, and then we will keep going. All right. So one of the first things in epidemiology is this idea of a descriptive study, right? And so here you're trying to determine possible risk factors. And so, I don't know, in elementary school, we were always taught for a story, right? Who, what, why, where, when, how. And these are the same kind of basic questions that they're trying to figure out, all right? And, again, you'll see as we kind of move forward a little bit, the level of complexity starts to kind of go up, right? So I kind of like to think of this as casting a wide net, right? Trying to figure out why, right, people are at risk, who's at risk, right? It's kind of you're just trying to gather all the information that you can and hoping that you hit on some of these risk factors, right? We then like to move right into, right, an analytical kind of approach, right? So that data and that information that you've gathered, for that descriptive study, right? Now you can really start to look at specifics, right? And so now you're trying to really identify those relevant risk factors. So really trying to narrow down or hone in on the information that you gathered in your descriptive study, right? And there's a couple different ways that you can do this, all right? Or identify these relevant risk factors, narrow down what we need to be concerned about. So one, right, is a cross-sectional analysis of the population. And, you know, in some cases you'll see compared to below, this is not as specific, but it's still, right, you're comparing infected versus non-infected individuals. Now, the problem here is, and this might depend on just how much data or information you have available, you're not necessarily getting more stringent than that, right? So you could have, you know, an infected white male, and you could have a non-infected black female, right? Or an infected Hispanic female and a non-infected Caucasian female. You know, in some cases you can be kind of limited, but it still might give you a good idea of what some of the relevant risk factors may be. Although what you're comparing might not be apples to apples, it may allow you to glean some type of information. Where I, right, think this gets really powerful is this idea of a retrospective study, all right? So in this case, you have your case subject, which is your infected subject, and then you have your non-infected control. And you want them matched, right, as best you can. So, you know, if I'm looking, you know, at you guys, right, so we'll pick on Elena. How old are you?
I'm 20.
Elena's 20, right? And so, you know, in the case of Elena, one of the things I may be looking for, let's say she was infected, right? Her control, I might be looking for a female, right? That is in her at least early 20s, maybe even an exact age match, right? And that's going to really allow me to hone in on those relevant risk factors, right? Because it lets things stand out, right? If I'm comparing Elena's infection to maybe a male of a different age, of a different ethnicity, you know, one of the things that's hard for me to tease out is, well, are the differences that I'm seeing between Elena and that individual just because of gender, ethnicity, and age? Or is it because, right? And so when you match as best you can, right? So for Elena, I'd find another, right, female that's around 20 years old. And that kind of eliminates some of those, I'll call them, you know, background risk factors that maybe aren't something that needs to be addressed, okay? And then prospective study, these are really interesting. Because basically what you're doing here is you say, okay, I think these are the risk factors that are relevant for this disease. And I know that this population or this group of people possesses most of those risk factors. And so what I'm going to do is I'm going to follow that population over a certain period of time and basically see what happens to them, right? And in case you're wondering, right, at the surface, you're kind of like, oh, this does not sound overly ethical. And in some cases, even in our history, it has not been used in an ethical manner. But nowadays, thankfully, because of institutional review boards and other kind of agencies that monitor these studies, right? You know, these patients know that they're part of a group, and these patients are given some type of medical intervention or treatment when they start to show, you know, whatever disease or pathology these scientists and doctors are trying to follow. Okay, but in some cases, right? If you've ever heard of the Tuskegee experiment, right, where they followed African American communities that had syphilis and basically faked treatments so they could follow the progression of the disease, right? And this happened in the United States. And so we certainly have our fair share of abuses of these studies or like studies. You know, next, right, when you have risk factors identified, you're confident those are the right ones, then you can really start to look at this idea of cause and effect, right? So here's where you start to implement drug studies. Here's where you start to implement intervention, right? And so how do you treat this disease or this pathology that you've identified, right? And because this is microbiology, right, we focus a lot on, you know, diseases that are caused by pathogen, rightfully so. But these same principles can be applied to cardiovascular diseases, right? Things like obesity, heart disease, you know, things like asthma, you know, all can follow these same general principles, right? For surveillance, right? I mentioned before that um, you know, having an understanding of what the endemic level of disease is important for determining when to kind of sound the alarm or when a more robust response is needed. All right. And so if, you know, I can see Elena still. So let's say she comes into the doctor, right? And the doctor actually determines she has rabies. Okay. That's definitely not good, right? And the CDC would be notified. But let's say she's the only person in the state, right? We don't all of a sudden, right, institute stay-at-home orders or stay away from stray cats, raccoons, and squirrel and fox orders, right? But if, you know, Elena comes in and then 2 days later, her doctor sees 3 more patients with rabies. And then he's talking to another doctor that's a town over, and he's seen 4 patients with rabies, right? All of a sudden, then we start to kind of go above that baseline level of disease that we expect to see. And that's when, right, maybe some intervention is needed. And one of the ways that we keep track of all this stuff is with MMWR's morbidity mortality weekly reports that are published by the CDC. They have notifiable diseases that they have to report on. So something like rabies, right? That information needs to be sent to the CDC so they can compile that information and determine if there's a huge issue, right? This is where you have case reports of patients that we see. And so this might not be a notifiable disease, but this could be something that's just, it's abnormal, right? It's not what a doctor would expect to see. And so again, when these case reports come in and they're kind of weird things that doctors are seeing and you're getting them from all over the place, right, they get compiled and then maybe you can see a pattern. And just to give you an example, and one of the ones that we're going to talk about here in just a second, briefly, I can pull this up and show you what one of these looks like. But you can go to the CDC, and they are completely, you know, free for you guys. I know it. Oh, here we go. Oh, crap. So this is one. Let's see. So this is one that we're going to talk about, you know, briefly today, but this is what it looks like, right? Morbidity, mortality weekly report. And this one is actually looking at COVID-19 in correctional and detention facilities, right? So what is it doing in the US prison system, all right? So it can be all kind of interesting, cool things like this. I have another one that I have that my students will probably read in the fall. I wanted to get ready for the fall or for this session for you guys, but I just didn't get to it. But one that's looking at measles outbreaks in Europe, right? Because of the anti-vaccination movement, we've seen a reoccurrence of measles. And so all that information gets put into these reports, and it allows us to track diseases that we know about, or it allows us to identify new diseases that we need to be you know, concerned about. And, you know, when we talk about corona, I think one of the things that's important to mention, and I'm sure you know heard, we talked about the difficulties of some people were calling it a Chinese virus, right, which is not accurate. Viruses don't have ethnicities. Although if you wanted to be specific, we could say virus that was transmitted from animals to humans in China, right? That's a mouth, full. But I think there's a lot of unfair hate put towards China. But one of the reasons that some people were kind of up in arms is because of the way certain things were handled over there, right? It made it harder for us to track or realize the severity of this infection because information was kept from us. And so that certainly slowed down, the epidemiological study response process on our part. But if any of you have been following news too, there certainly are a lot of things that I think we could say the United States did not handle or do well at the beginning of this pandemic that have kind of led us to our current situation, right? So a lot of kind of, we'll say, public health and epidemiological failures across the board and as a world population, not just one country. Right. So epidemiology, what are some of the things, that they're concerned about? And clearly we're living during a pandemic. So you probably know that emerging diseases are a big deal. Ebola, which again, from a research medical perspective, sometimes I'm surprised how high on the list it is. It is a very, we'll say, unpleasant infection to deal with, but is very isolated to the world and is relatively easy to contain once we know it's happening. D68 enterovirus, this is actually a virus that was identified in the 1960s, and it's kind of like I'd say like a SARS or like a COVID or coronavirus type deal here that we're starting to see maybe kind of reemerge. And so we get concerned about things that we thought were gone or maybe making a comeback. Epidemiologists, daycares are a really interesting kind of a study. Your parents, more than likely, probably were not at large daycares, right, that we see now. In the grand scheme of things, this is a relatively recent development. Now, I was going to daycare, starting in the 1980s. But a lot of your parents are in their 50s, 60s, grandparents, 70s, 80s. This was not a thing. And daycares, when you decide to have children, they are a godsend, so that you can get things done. But more than likely, your kid will probably be sick every other week, right? I consider them disease cesspools where everyone comes together. And Professor Perry can back me up here because when my daughter was sick, she got to hang out in our office, and Professor Perry got to see Emmeline a lot during the fall. We had a tough bout, but it's another chance for interaction between people that normally wouldn't come together, right? And then you add the fact on to it that not only are they spreading disease amongst themselves in daycare, right? But then they're taking it back home with them to their parents who may interact with other people. And so it's a whole nother chance, right? There's a lot of incredible things about modern society, about bringing people together, about communication, about travel, that we love and enjoy, right? But that also make it a lot easier for pathogens to spread quickly, all right? And, again, COVID-19 is another, great example of that, right? International travel played a huge role in the spread of that virus. And when you can jump on a plane and be on another continent, sometimes in a matter of hours, right, the possibilities are kind of endless, right? What we also see now, sorry, got to close my door. Emmeline's coming back in. All right. Now, I will say, too, go back to daycare really quick, because this is like the healthiest she's been in a long time because she hasn't been in daycare. But my mental health is starting to suffer, right? So we all pay the price somewhere. Well, what we're also seeing now, too, interestingly, is an evolution of viruses, an evolution of drug-resistant bacteria. Professor Perry can just nod. I haven't really looked into it, but I assume we have drug resistant fungi now that we're seeing. True, right? And so this is just becoming kind of a global, issue. And this again, I don't know where you stand on the evolution view of things, but one thing we can all agree on is that microevolution is a thing, and we're seeing this across all kind of pathogenic microbes, right? Viruses, drug-resistant bacteria. I could add fungi on there. You pretty much name it. Actually, drug-resistant protozoa. We even, could add on here that's interesting is drug-resistant, reservoirs or vectors, right? So, we use pesticides to try to destroy or kill mosquitoes, right? To stop the spread of some of the things that they spread. And we're noticing they're becoming resistant to the pesticides. And so the thing that's transmitting the disease is resistant to what we're, right? And so there's just a lot of evolution that's going on. And I did like the video you have to watch on Moodle that I posted, and the video we watched yesterday, right, was doing like the cheetah gazelle thing, which seems to be, kind of one of the common comparisons, in that when one runs fast, the other evolves to run faster. And we see a lot of that going on. Misinformation, right? This is a big one. And I put vaccinations, on here because the anti-vaccination movement is strong. And there's a lot of ways that this happens. I put holistic approaches on here, and please don't think that I'm against holistic approaches. I think they can be useful as supplementation for other treatments, and some of them may prove someday to be even longer lasting or more important treatments. But the problem with a lot of these is that they aren't regulated the same way. And we run into issues, right? If you have something like meningitis, all right, well, you can go and drink all the herbal tea that you want, right? But it's not going to do anything. And we do see things like that kind of popping up or becoming, more common. And there's a lot of reasons for this. One of the biggest ones, and I hope you read that vaccine paper, but if you haven't, that they talk about in there is, this idea of trust. And so for a multitude of reasons, there's not trust between patients and providers. And so how do we kind of bridge that gap? And if there's trust, then there can be conversation and hopefully treatment, right? But it's really risky when we talk about social media, the way information is sent out or spread. The fact that we don't, check sources anymore. We just kind of we see things, we follow the clickbait, and that's how we're getting some of our information. Some of you that know Dr. Moy, I was talking to him a couple of days ago, and one of his rules of thumb is if an article cites anything from Twitter or Instagram, he immediately stops reading it and moves on to something else, right? And so, how can we be responsible about how we spread and share information, and how can we be responsible about how we consume information, right? I don't have the answer for you, but that is an issue that we have to deal with, as we move forward. And again, modern life, we've already pointed out some of these. Travel, cities, right? Those of you that have been to New York, maybe you love New York, right? It has some good things to offer. I guess, I can do New York for 2 or 3 days and then I'm kind of done with it. But if any of you have been there, right, it is super crowded. People are living on top of each other. Some of the conditions in larger cities are not that great. So you take a lot of people living together, maybe not great conditions. Just the fact that you have to interact with people. Think about things like subways, right? A lot of people use those, close proximity, just all that stuff. If any of you follow the COVID-19, pandemic, things are bad in the United States, right? It's spread a lot more than we initially thought. I also would argue if you would take New York away from our statistical data, it might make it look slightly different. I mean, New York was bad, right? And the hotspots appear to be in these bigger cities. And it's not that big cities are bad. It's just that big cities kind of are perfect breeding grounds for some of these, viruses, all right, or other pathogens. Okay, and so a lot of the things that we enjoy, I would also argue, fortunately or unfortunately, depending on how you look at it, like part of our modern life in the United States is that although it can be abused and it's not perfect, I think our freedom or our tendency to want freedom has made the corona or the COVID-19 pandemic even worse, right? We're used to being able to do what we want. Our value system as a country is a little different. You see places, like South Korea that have a different kind of, I think, view of family interaction with people, and they've controlled the spread of COVID-19 better than we have. You see places like China, which again, I'm not here to talk about how accurate the numbers are, right? You can read on that yourself. But because they live under a communist regime, they are able to implement martial law and kind of keep people inside and keep crowds down. My wife has a friend that's a missionary in Jordan, and I'm not sure what the restrictions are now, but at the start of the pandemic, no one was allowed to leave their house, and bread and water were being dropped off by the government once a week. I'm not saying that that's good, but it certainly probably helps control the spread of the virus, right? And so there's just a lot of things that play into this. And sometimes the freedom that we enjoy, the benefits of modern life that we enjoy are perfect kind of, breeding grounds for some of these, pathogens, right? I don't think we talk about it here, but I'll mention like one of my favorite things about grocery stores, right? If you go, there's a little misters, right? And the little misters there, there's a chance that they could spread Legionella disease, right? And I don't think anybody chose that as a topic, but it's just kind of a modern benefit of having fresh produce in our grocery stores, right? There's a lot of things that play into this. Again, public health, one of the big things that the field is dealing with now are these hospital-acquired infections. And so here you see 5 to 10% of all patients admitted to hospitals in the US leave with something that they didn't come in with, all right? So C. diff, E. coli, norovirus, Pseudomonas, depending on the health of the patient, these can be severe or even deadly infections. MRSA is something that we're really fearful of now. And because of modern HIV medications, which we'll talk about, people consider MRSA more deadly than AIDS. It's harder to deal with, okay? This is an article that links and talks about some of this different stuff. And again, this comes down to, responsibility from patients and from healthcare workers. Oliver Wendell Holmes and Ignaz Semmelweis, again, these are both guys that the very simple idea of, hand washing, being clean in between seeing patients. We think about it as small, but it really revolutionized the healthcare field. And some of these things to prevent some of these hospital-acquired infections are really just more of a commitment to the basics. Okay? So what I want to talk about here briefly are U.S. prisons, right? And so this is actually the MMWR that I showed you. It was published May 6th, and it had data in it that was collected April 22nd and 28th, right? So this is, already about a month old as far as when it was published, but that's incredibly recent and relevant data, right? This is moving fast, so it's hard to keep up with what's coming out. But just to put it in perspective, right, why do we care about this? Well, in the United States, right, we have 2.1 million adults that are in some type of prison or detention facility spread out over 5,000 facilities across the United States. And this does not include, right, this data did not include juvenile facilities, right, which may also be dealing with some issues. And so this is data that was collected, right, during the week of April 22nd to 28th, right? So just a little over a month ago. And in this case, data was collected from 37 to 54 state and territorial health department jurisdictions, right? And so Again, not to get into U.S. history and geography, right? But we know we have like territories, right? So that'd be like Guam, the U.S. Virgin Islands, fall into that group of territories, right? So some of you are probably like, "There's only 50 states." Well, you're right, but we have some other kind of territories and stuff that fit in, and so 86% of those 37 jurisdictions that reported, right, had at least one case of COVID-19. So that was 32 of the 37 that reported, right? That gives you 86% reported at least one case of COVID-19. Across those facilities, right, you had about 5,000 inmates that tested positive with about 90 deaths. And then you had just under 3,000 staff members, right? And that could be guards, um, even nurses and doctors that may work in the prison, and all the different people that kind of help run a prison, right? So about 3,000 of them tested positive with about 15 deaths. All right. And so one of the reasons that we get concerned, right, is that kind of like a big city, right? Prisons and detention facilities can be kind of that perfect storm of when a infectious pathogen is running through society, right? They have a lot of the things that work against them, right? So they're often crowded, right? They have shared bathrooms along with other facilities, limited medical and isolation resources, right? And so, the prison might have kind of like a small clinic, maybe with a couple beds, maybe, right? But that's not always the case. And so it's not a spot where medical intervention can easily occur. What can be challenging here is that you have daily entry and exit of staff members and even visitors. Now, I haven't really checked local prisons, but I guarantee that most of them are probably not taking visitors right now. But the staff that helps run them, right? They go home at the end of the day and they come back in the next day. A thing that we are concerned about is that some staff members actually work at more than one prison. And so there's a concern that staff members may actually be one of the main reasons that COVID-19 is being spread within these prisons and detention facilities. You have the arrival of new prisoners, right? One thing that's hard to do, and let's say it's like a really extreme crime like murder. Well, you can't be like, well, you just go on house arrest until this pandemic's over, and then we'll come and get you and put you in prison. Right now, like prisoners have to go to prison, and so we have to bring them in. What we also see is that a lot of times inmates are transported together, and so this could be maybe they're all going to see the doctor off-site together. Maybe they're all going. A couple of them are going to like a court date together. Right. And so there's a lot of time when you're together and interacting with other prisoners. Okay. And so this is actually from that MMWR. So this is kind of their guidelines or their suggested guidelines for, helping to stop the spread or limit the spread of the COVID-19 virus, in prison. And this is where, as a country too, you can, kind of argue that sometimes it becomes a little confusing or complicated because some of these guidelines are kind of open-ended, right? So update an emergency plan for COVID-19 response. All right, that makes sense, but, a prison facility might not know what that means. Now, one thing that could help, right, is coordinating with the local public health department or other correctional and detention facilities, right? So again, trying to work together and developing a plan, right? Planning for potential staff member shortages, right? Focusing more on cleaning your facility, limiting non-medical transfers into and out of the facility, right? So really, if you can, right, cut down on the number of times that you're bringing people in or bringing people out. if possible. I can't remember if it's on here, but one of the things that it said, especially for minor crimes, maybe you do put them on like some type of house arrest, um, to try to reduce the strain on the system, right? Um, and this is where it becomes challenging though. So use multiple physical distancing strategies. Uh, and so just depending on the size of the prison, this may not be something that's easily implemented. Um, and so you can certainly see how prisons are a challenge. And again, not that you're as worried about the prisoners spreading it to the general population because they're in prison, but right, if it is the staff members that are either spreading it to the prisoners or staff members are getting it from prisoners and then going home, this becomes kind of a big issue. And one of the things that's challenging, right, when you look at this data, right, is that you still have, what is it, 16, no, 17, 17 jurisdictions that didn't report their information. So these numbers might be even higher. One of the things that was interesting this paper mentioned is that prisons and detention facilities at the time this was written were not equipped to do COVID-19 testing. And so, or do COVID-19 testing for their staff members. And so all the staff members, those numbers where we said about 3,000, those were all self-reported cases, right? So the staff members had to go find their own tests, get tested, and then report back. And so that may be, a really big, we may be underestimating significantly because there's probably more people that just didn't go and get tested, or for whatever reason, maybe you got tested, you turned out to be positive, but you didn't want to miss work. I don't know, right? And so we feel pretty confident this is an underestimation of data. And I also like this article because it brings to light, we get really caught up in ourselves and we forget about people like prisoners, right? Or inmates, right? And regardless of the crime or what they did to get in there, right? They deserve to be treated, right, as well as they can be treated in facilities, that they're in. And so, they are dealing with this too. And again, we should really care about it from the perspective of the staff members and the people that are working there can spread it and bring it home. And so this is something, right, that I think a lot of people don't realize needs to be addressed. And if you actually will go online and search Pennsylvania, one of the hot spots where I went to college, there's a federal and state prison in the same county. And they have had, and this county's in the middle of nowhere in Pennsylvania, and they had like one of the highest, at least for a while, were turning out the highest COVID-19 numbers in the state because it was running through the local prisons. All right. So again, infectious disease, old and new. And so, epidemiology and public health is interesting because it is dealing with a lot of old or new stuff, but it's also dealing with stuff that's been around, for a while. So HIV is actually relatively new. Malaria has been around for a long time. Tuberculosis, Ebola is new. Smallpox, the plague, right? They are really old diseases, but we're concerned about these from a public health perspective. And so what we're going to do now for at least a little bit is talk about HIV. Again, I know this data is a little dated, but it is still relevant. And what you see here is a heat map of HIV, right? So the darker blue, right, represents a higher percentage of HIV cases. So interestingly, right, in North America, and I'd have to check probably even the United States, we have more people living with HIV than we do in some of these sub-Saharan African countries. But the percentage of the population that has HIV is significantly higher in these sub-Saharan African countries. In fact, at one point in certain sub-Saharan African countries, it was estimated that up to 20% of the population may have had HIV, right? So it's a really kind of big issue, especially in Africa. Not that we're not concerned with it in the United States. And I just wanted to point out too, with this heat map, please don't think that like China and Russia don't have HIV cases. right? They were just not forthcoming with reporting the information. And even in COVID-19, I think Russia had kind of lagged behind in reporting. And, there are, I think, reports now coming out that it's a pretty big issue there also, right? So that just means that, there aren't cases typically being reported here in these countries, all right? So this, again, is a global pandemic. And you can see worldwide, right? I mean, this is a big number, right? 0.8%. That's approaching 1% of the world's population. That's not a tiny number. All right. So, for AIDS, HIV, right? Remember, AIDS is acquired immunodeficiency syndrome. This is what you get later during the infection cycle, right? And so it's not actually the virus, the human immunodeficiency virus that's killing you, right? But it's infections that result from a weakened immune system, right? And that's when you, right, hit AIDS, right? When you start to become infected with pathogens that normally would not cause an issue in healthy individuals. And this is just to kind of show a little bit of the complexity of the virus. So HIV-1, when you guys think of HIV infection, this is typically what you're thinking of. And you can see here, you have this HIV-1 M group. We'll talk about this in just a second. This is where the majority of HIV cases come from, but you have some other kind of branches off here. This is simian, right? So these are basically primate versions of the virus. Here's HIV-2, which can infect humans but does not cause as severe infections. And here's more simian primate versions of the virus. And one thing I just want to kind of point out on this branch is that you see these kind of different subtypes of HIV that cause the majority of infections in people. And I want to kind of point this out because, again, one of the things when we talk about COVID-19 and this idea of, well, just make a vaccine and life will be back to normal, right? Making vaccines sometimes is a little more challenging, than we realize. And I don't know, right? Some people may be like, well, if we're making a vaccine as quickly for COVID-19, why can't we do it for HIV? And people have been working on an HIV vaccine for years, but because of the variety of subtypes of the virus that cause infection, with a lot of other things piled on top of that, it's very difficult to develop an effective vaccine. And we'll talk about another reason here in just a little bit why this is not not a major concern like it used to be, which I think is unfortunate. But for AIDS, HIV, right? Remember one of the things we talked about SARS-CoV-2, right? The COVID-19 virus, is that it likes to attach to the ACE2 receptor in your respiratory system and your gastrointestinal system. Well, HIV, right, is looking for the CD4 receptor, right, on T helper cells, and CCR5 or CXCR4 co-receptors, right? And what you see, right, or where you find the CCR5 or CXCR4 receptors are on macrophages, dendritic cells, T cells, and then T cells and new neurons, right? There's actually interesting research looking at the brain in HIV and showing that the virus can actually potentially hide in neurons, which makes it really hard to treat. But here you can see, right, kind of attacking directly the adaptive immune system, or, right, kind of interacting with those cells that bridge the gap between the innate and adaptive immune system, right? So this is really really a big deal when it comes to someone's immune system, right? And ultimately what's going to happen is you're going to have a CD4 T cell, right? The T helper cells are going to start to die. And once they die, then you have no regulation of the adaptive and no regulation of the innate immune system. And this is why people develop AIDS, right? The acquired immunodeficiency syndrome, and succumb to really common infections that would not probably even make you mildly ill. This is HIV progression, and what I love about this chart is I think it really kind of emphasizes what's happening to your immune system, and it also emphasizes why it was so hard for us to see this infection coming, and why it was so hard for us to initially track the infection. All right, so this is kind of a what do we know now? Interestingly, when you first get infected by HIV, Um, you see that you have flu-like symptoms. What you also have on patients that physicians have noticed is you get a small rash on your back. All right. But unless you think for some reason, or you have reason to think that you've been exposed, most patients have no idea, right? It's a little rash and it goes away. And so if you get diagnosed that way, or if it's caught that way, that's kind of like incredibly lucky. Um, but that doesn't happen much. And so what you see initially is upon infection, early on, you have a spike in circulating HIV virus, which is the red, and then circulating HIV RNA, which is the green. All right. And you see this immediate decline in your CD4 T cell number, right? So early on in infection, right, the virus likes to go after those cells, they decline. But during the infection, it doesn't return all the way to normal, but you actually do see, right, growth of that population, or that population increases again of those CD4 T cells. All right. And what's interesting about HIV is that you see here, right, so asymptomatic, and again, this can go on for years, your CD4 T cell count continues to decline slowly over time, but even like down here, right, whatever this imaginary point is, you have enough CD4 T cells that are functioning normally that you can continue to fight common infections. Your immune system continues to work. At some point, though, represented by this dotted line, there's a threshold. All right. And once you hit that threshold, your CD4 T cells, even if you have some left, they can't keep up with the infections that your body is encountering. All right. And what made HIV challenging initially is that one of the ways we looked for is we tried to find the virus in circulation, right? And you wouldn't see it. All right. And so again, you didn't see the virus in these people. They were asymptomatic. And so in some cases you thought, maybe they're normal. And then it's years and years later that you kind of hit this AIDS stage. Then you can finally see the virus again. But by that point, it's too late. All right. And so when we test for HIV now, right, you can look for circulating RNA, which you see remains relatively high. You can also look for certain proteins that are in the envelope of the virus that we can detect in circulation. And so we're a lot better now at detecting the virus than we were before. All right, so very challenging to detect it. So I already mentioned here, HIV-1, specifically group M. M stands for major, so 90% of all HIV infections come from this group. You saw in that little chart that I showed you, there's a bunch of different subtypes. What we notice, and is very interesting, is that the subtypes are regional. So in North America, we have subtype B. In Northern Africa, Sub-Saharan Africa, parts of Asia, right, they have different subtypes. You also have group N, which conveniently is non-M or non-O. Only about 10 cases have been identified worldwide. This number's probably gone up since I made this slide, or Dr. Chris maybe even made this one for me a while ago. Group O, right, for outlier, this is only 2% of HIV infection, right? And we have group P for pending, right? We don't really know where it gets classified yet. I mentioned HIV-2. It also has 8 subtypes closely related to SIV. So this is a simian immunodeficiency virus, right? Causes infections in primates. And, this is mild symptoms compared to HIV. And to the best of my knowledge, these patients don't typically progress all the way to AIDS. All right, so let's talk about origins, right? This is what epidemiology and public health, right? We're really interested in how did these things start? Where did they come from? So again, to the best of our knowledge, right, we believe that its origins in Africa are from Cameroon, right? And it started off as simian immunodeficiency virus. The idea being that primates were slaughtered, right, for food, right, as a food source. And maybe during this butchering process, right, the virus was transmitted from primate to man. A common theme that you'll see with some of these viruses, again, if you go back, I forgot to look up that video for you. Well, maybe we'll start with that tomorrow. But the Chinese wet markets, where you have a bunch of these exotic animals that are brought and put in close proximity with one another, and they're slaughtered on spot and then sold on spot, right? There's just a lot of chances for interaction and for the virus or for viruses and pathogens to jump, right? So in Cameroon, we believe that HIV-1 made 3 separate jumps, becoming the M group, the N group, and the O group. And what we know about HIV right now is that it's transmitted by blood and bodily fluids. It can be transmitted via vertical transmission. What's vertical transmission? Does anyone know?
It's like generation, like mother to baby.
Yeah, mother to baby, right? So, the virus is able to cross the placental barrier and cause infection. Kind of like talking about malaria, right? With Mercy's article, it appears that if a mother has an active malaria, right, infection, that infection can be passed on from mother to baby, okay? It's not the case with all diseases. All right.
I
So
have a question, Dr. Dash.
yes, ma'am.
So, is it possible for HIV positive mother to give birth to an HIV negative baby?
Ooh, that's a good question. Hold that thought, and we'll actually get to that towards the end of this lecture. Okay.
Okay.
We'll address that. Yes, that is an important point, right? AIDS, HIV, right? So our first known positive sample is actually from 1959. Now, again, they weren't looking for the virus in 1959, but these are samples that were preserved, right? And so we were able to go back and look at these samples. So a blood sample from 1959, right, tested positive for the virus. Hey, Emmeline. Emmeline has learned how to knock on doors. So 1960, right, we actually have an infected lymph node sample. And the thing that is intriguing about these samples is the fact that they're kind of the late 50s, early 60s. And so presumably, right, the virus could have, been or had made its jump to humans maybe sometime in the 1940s or even earlier, all right? Because again, it's typically years and years before we're able to detect these things. And so if they're able to detect them in samples that were preserved, that patient could have had it well before that. In the United States, the first positive sample, again, this is retrospective studying, right? This was confirmed in 1987, came from a young man named Robert Rayford. He was 15 years old. The way that they first noticed something was wrong with him, even in the 1960s, he had something called Kaposi sarcoma, which is a rare form of cancer. You'll see a picture of it in just a second. We'll talk about it a little bit more. But he actually came into this was in St. Louis, so he went to Washington University. They have a hospital there that they run. And, he wasn't forthcoming about all of his medical history with the doctors that were treating him. What we do think, looking back at his case file, is that more than likely he had been a child prostitute and had caught the virus that way. What's also interesting is that, to the best of our knowledge, he never left kind of the greater St. Louis area, so he never went outside of Missouri. So that means, right, that someone brought the virus in. And again, if he was showing these symptoms, and this was 1969, and he said he had been having these symptoms for about 3 years, so his symptoms started in 1966-ish. It could have been, again, right, HIV could have been in the United States maybe as early as the 1950s. For Europe, right, and we kind of see these kind of separate events. Europe, 1976, Arvid No, this is kind of like a pen name that was given to this guy to protect his identity. Early on was the first identified case in Europe, or kind of looking retrospectively, and it turns out he was Dutch, and he was like a tradesman, right? So he went to Congo in the 1960s. He loved, I guess, not loved, I don't know. He visited prostitutes, so we think that he acquired the infection by visiting prostitutes. And then when he went back to Europe, he was a trucker, and he would sleep with prostitutes at the different truck stops. and that's how he spread HIV. And so that's actually how they figured out that he was kind of, patient zero. Is they looked at like these kind of clusters of prostitutes that all had HIV, and they traced it back to him. He's also the first case that we know of, kind of like a family cluster of deaths. So his wife and child eventually died from the virus that they got from him. For the United States, and I should have put this maybe under the US thing, so I'm sorry about that. Again, to the best of our knowledge, when we can kind of trace things, we think that the virus, again, originated for us, the version we have in the Congo. It was then transported to Haiti, and then it came to the United States. All right. So this is Kaposi's sarcoma, and it is very, very rare. It's tumors that form just under the skin. Typically, it's very slowly progressing and does not have an effect on quality of life or length of life. But in these patients, or in HIV patients, because they have no immune system to help control the cancer, it moves really, really quickly. All right. And the reason that I show this and that it matters is these are kind of screenshots of MMWRs from the early 1980s, right? So here's July 1981, and this is June 1981, and this is data that was being collected as early as 1980 in these two reports, right? And what you see on these reports is Kaposi sarcoma and pneumocystis pneumonia among homosexual men in New York City and California. And here you see pneumocystis pneumonia in Los Angeles, California. And basically what started to happen in the early 80s is doctors started to see men that were coming in that had recently been relatively healthy and were presenting with really rare infections, all right? And enough of these patients started to come in, right, that people started filing these MMWRs with the CDC. And this is how we actually, caught wind or figured out that we were in the midst of an HIV epidemic. And then we see, right, with information from the rest of the world that it was in fact a pandemic. And again, you see the populations here, right, all active homosexuals, right, this is among homosexual men. And so this is the first population that the HIV virus was identified in. And you can see here, 1981, the first name of the virus was gay-related immunodeficiency. You then went to the 4 H's. Does anyone know what the 4 H's are? You know what one of them is based on the slide I'm presenting? What do you guess one of the H's is? Come on. What's an H word that's on this slide that's related to HIV? Ooh, you guys are, I feel the energy coming forth from you today.
Homosexual.
Okay, so homosexual is one of them. How did I say the virus came to the United States? From what country?
Haiti.
Okay, so homosexual, Haitian. The other two, if you got these, I'd be really impressed. What's an H drug that's spread by sharing needles, or that you inject into your arm that starts an H?
Heroin.
Heroin. All right. And the other one, this is super sad, and we'll touch on this in a second, is hemophiliacs. All right. So these are kind of the populations that we initially were noticing this in: homosexuals, Haitians, heroin users, and hemophiliacs. All right. Does anyone know what is a hemophiliac? What's someone that has hemophilia? What do
They have like blood clotting problems. So
they
they
have
need
blood clotting problems. So then what do we do?
Blood transfusion.
Blood
And so
transfusion.
infected.
Right. So Megan answered that question. And so this is something interesting to think about, right? If, right, the HIV virus clearly had been being spread before 1980, right, if that's when we see patients presenting, because they could have had it in their system for years, right, and been asymptomatic. And even when it first started, we didn't have a great way at detecting it. We didn't understand a lot about the virus. And so during all of this time, right, people that had the virus, right, or people that had the virus were capable of donating blood to like the Red Cross, right? And they didn't know about the infection. Even when they knew about the infection, they didn't know how to screen for it. So this HIV was not something that we were screening for. And so, you know, if you Google Ryan White, look up his story. It's super sad. He was, I think, late elementary school, early middle school when he went in for a blood transfusion because he had hemophilia, and he came out with HIV, right? He ended up getting an HIV infection. And so these were patients that were just going in for their normal treatment, right? Weren't, you know, making any decisions that would have knowingly exposed them to the virus, right? And they acquired it, right? And so this is a kind of a really sad, right? It happened to a lot of hemophiliac patients. If you go look up Ryan White's story, the other parents in his school district made the school board kick him out of school because this is before we really understood how the virus was transmitted. So it's just kind of super sad story. He actually became an advocate and spoke, became kind of like a public speaker for the virus. But he died within a couple of years, you know, of being diagnosed. But look him up; it's a worthwhile, I think, a read for some of you. All right, and then here we go. Sorry, and then we eventually settled on AIDS in 1982. If you're also up for a good chuckle, I can't remember exactly how they spelled it, but there's a dietary supplement in the early 1980s called AIDS. You can find the commercial on YouTube, and it's just you know, kind of inconvenient timing that was the name of their dietary supplement as a pandemic was starting. But let me end here. Let's see. Oop. Nope, I don't want to do that. But that's okay. Okay, so we have about 12 slides left, and I think some of this stuff is important, but I don't want to keep on going too much longer. And we have enough time built in after your presentations that we can finish this up, and maybe we'll do this and then talk about leprosy because it's relatively short tomorrow. So what I'm going to do, you know, now again, is break you up into your groups from before. And again, I'm just asking that you work for at least half an hour together. I'll kind of check in with you. I know some of you were flagging me down for questions. I'm totally willing to answer those or talk to you about your you know, projects. You should hopefully have something that you could show me when I swing by today. Also remember to check your disease presentations. I think if you're highlighted in orange, you're tomorrow. If you're highlighted in blue, you're Thursday. I could have those colors mixed up, but I have that labeled on your thing. So just keep an eye on that and be ready to go. What I'll do today too, as soon as I put you in your groups, is I'll open up the Dropbox for your presentations, right? You can share from your computer when you present, but that way you can all see each other's presentations when they're done and as you're preparing for the exam. All right, cool. I'm gonna put you in your groups and then we can get to it.